The next.
So I would request the attention of all the respected members. Kindly allow me a few minutes of yours and let me introduce myself and introduce the faculty members of this session. Good evening and welcome to one and all. I'm Rituparna from Clarinet, the designated session assistant for a seamless experience. And Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. Clarinet is very proud to be digital partner for this event named Cancer Recurrence, Are We the Culprits? Organized by the Society of Anaesthesia and Perioperative Care. So without any wasting any further minute, let's begin today's session, for which I would like to invite Dr. Rakesh Garg from Society of Anaesthesia and Perioperative Care to take over. Over to you, sir. Please proceed.
Thank you so much, Madam, for this SOPSI webinar. And I also thank the SOPSI organizers for giving this opportunity to talk on the important topic, which is important from regards of the various oncosurgical procedures. And today we have a panel of experts with us who will be taking us through the various nitty-gritties when we talk about the cancer surgeries, especially in the perioperative period. We have panelists with a vast experience in various oncosurgical procedures, and we're discussing more about the experience-based practice with regards to the oncosurgical.
Your audio is gone.
Sorry to interrupt you, Rakesh sir. You are muted again.
Right. So we can think of those experience-based things from our experts. And we have galaxy of experts with us. We have Dr. Sanjay Upadhyay, who is head Department of Anesthesiology and Critical Care. He's also Director Academics and Member Secretary at Ethics Committee of Asian Cancer Institute. He also is associated with Breach Candy Hospital and Reza Fortis Hospital. He has a vast experience, clinical experience, in addition to his academic commitments. And he's the most apt person to talk about various perioperative care and any concerns. We also have with Dr. Raj Sahajanandan. He was working as Professor CMC Vellore. Now, presently, he's working as Senior Consultant at Sultan Qaboos Comprehensive Cancer Care and Research Center. Dr. Raj Sobin will be joining a little late. She is at Max Super Specialty Hospital, Saket. And we also have Dr. Lalita Gauri Mitra. Madam is Professor and Officer in Charge at Anesthesia, Critical Care Medicine and Pain Department at Homi Bhabha Cancer Hospital and Research Center at Chandigarh. And also she is having additional responsibility of the Homi Bhabha Cancer Hospital of Sangrur, Punjab. So I think we will take all those experience from our panelists. So when we talk about the surgery for cancer, yes, we know a lot of advancement, a lot of evidence has come that what should be the optimal perioperative care for patients who are undergoing cancer surgery. Usually we think that the anesthesia technique or the drugs or the strategy is quite benign for our patients. And usually we think that majority of the strategy that we follow for our patients in the perioperative care, especially in the recent times, appears to be more safer. The drug, the combination of drugs, the regional techniques, or the other strategies which have come with evidence in journal appears to be safe. So I come a very broad question to Dr. Sanjay and Dr. Raj presently. Do you think when we talk about cancer, do you think are we the real culprits, or do you think it is just a misnomer which has come from various hypotheses in the beginning, but yet we do not have much robust evidence? Are we doing something wrong if the selection of the technique is not apt, not particularly with regards to patient, but with regards to patient with cancer or a perioperative cancer surgeries? Dr. Raj, please.
Okay, thank you, Dr. Rakesh, for that question.
Um, if you want me to answer it in a single word, with the current evidence, there is no, we cannot say that we are responsible for cancer recurrence or affecting cancer survival. But that answer is not that very simple. To understand it, it's important to understand the survival from cancer. So there are a few things which has changed recently. Cancer has probably overtaken cardiovascular disease as the major cause of death in the world. And when you look at cancer mortality, so that's what we are all worrying, or when you talk about cancer survival or cancer recurrence, ultimately we are talking about the mortality from cancer. So there are a few things which we need to look at. If you look at the overall 30-day mortality, this is important. Uh, uh, it's about 2%. That's in the developed countries. But if you look at the developing world, probably the mortality rate is higher. And this 30-day mortality is primarily is determined by cardiovascular diseases. And again, when you remember the fact that many of our patients are elderly, have significant cardiovascular comorbidities, this is something where we can make a difference. So if we are not doing the right job, sometimes the morbidity and the post-op complications may not allow the patient to complete the intended oncological treatment, so that we can make a difference. The second important aspect is the 1 year mortality, or probably 5-year mortality. When we talk about mortality from 1 year onwards, it's ultimately the cancer itself, or the recurrence or metastasis from cancer, that determines survival. So, what is apart from the, if you look at the solid organ tumors, surgery forms a definitive treatment for solid organ tumor. But what ultimately determines the long-term survival is the post-op chemotherapy, radiotherapy, which is planned as a multidisciplinary treatment. So, if we are not careful and produce complications, that treatment or the intended oncological therapy can be delayed. So we definitely have a role, but whether we can implicate it directly or our techniques can be implicated directly, at the moment there is no evidence.
Absolutely right. I think to a certain extent, you're absolutely right that it's basically a team approach for a perioperative care. When we talk about the non-cancer patients, you have very nicely brought about a term of riot. When we talk about the other patients, the benign surgeries, usually the patient gets the surgery done, the post-operative care is being provided, and then he goes back without looking backwards for some additional treatment. But when we talk about the cancer patients, many of these cancer patients would require some adjuvant therapies, maybe in the form of chemotherapy or radiotherapy or a combination of it, subsequent to the surgical procedure. And this is a time-bound manner. It has to be done, say, within 4 to 6 weeks. So the patient has to return back to the continuity of the care in the form of the therapeutic treatment for these patients. And we cannot extend the post-operative period to a prolonged period. So he has to be fit to accept and tolerate the post-operative treatment which is intended for these patients. And that's why we should be cautious to make these patients do whatever techniques we do so that they can undergo those therapies. Coming to Dr. Sanjay, sir, the Dr. Naz was mentioning about the metastasis, or sometimes when we do the surgical procedures, I think there could be many reasons for the metastasis to happen. I'm sure that it's just not the anesthesia technique. Can you just elaborate upon maybe what is the pathophysiology of metastasis that happens in the perioperative period? What are the factors that probably can lead to increased risk of metastasis? Over to you, sir.
Yeah, thank you for getting me on this panel. You asked a question whether we are contributing to the frequency of recurrence in the post-operative period. All right. That for that purpose, you must try to find out in the perioperative period what are the factors which can lead to increased rate of recurrence. I think the bigger culprit is the surgery itself. And I will go backward a little even before surgery. If you have patients who received chemotherapy and radiation, that is also a culprit. So a combination of treatment for cancer itself is a culprit to cause recurrence in the post-operative period. Now, what is metastasis? Metastasis is something the tumor cells, they evade the immune response of the patient. They play hide and seek with it, the immune response. And if the immune response is non on guard, if it is suppressed by anything, that is the reason why the metastasis will occur in the distant organs. The surgery itself, by the nature of its resection, can cause a local recurrence by the spill, that is number one. It can release the tumor cells in the bloodstream, the tumor emboli into the lymphatics, and a distant spread can occur. So surgery itself is a very big culprit. Now, having said that, it's a necessary evil. You can't do without surgery, and the surgery can't do without producing such kinds of consequences. So metastasis occurs because of the treatments itself. Chemotherapy received in the preoperative period reduces the immunity of the patient. You know, along with chemotherapeutic agents, they are always supplemented with steroids. Another reason for depressed immunity. These factors combine together. Now, as the molecular studies are going ahead, we keep hearing about the tumor under treatment getting mutated genetically and also making the chemotherapeutic agent selected ineffective. So, all these factors combined together lead to the rate of recurrence. That is why even after you have clearly resected margins of a solid tumor, you send the sample of the patient to laboratory to find out if the genes have mutated. If they have, the patient is further treated with uh, immunity boosting drugs and chemotherapy. So it's such a complex phenomena, occurrence of recurrence, to find out from the whole set of literature or some studies whether anesthesia contributes to the recurrence is a gigantic task. Whatever, and that is why. But having said so, we have to keep in mind that since last decade we are debating this, or more than that. So there is some fire somewhere, because there cannot be a smoke without fire. And from laboratory studies, we have found out certain things positively contributing to the recurrence. So I think the technique of anesthesia which we employ for treating surgical patients in oncology is fairly standardized. Though, if there is a laboratory or material evidence, however weak it may be, there to suggest that certain agents or techniques may lead to helping recurrence, then we have to give a thought to it. That's what I think.
You're right, sir. I think very rightly said that when we talk about the
Rakesh,
yeah.
Yeah, can I add one thing to that?
Yeah,
So,
sure.
in addition to what Sanjay sir said, there is one more thing probably which I was thinking. Um, it is important for anesthesiologists because sir is a very experienced person who has been doing various type of surgical anesthesia for a long time. But for all the budding youngsters, it is very important to understand this pathophysiology, because even if you don't do harm, or you should not contribute to the harm, because as sir said, this surgery is a necessary evil. You cannot get away from not doing the surgery, but this inflammatory process and immunomodulation is likely to stay for a week, and it is supposed to peak at about 3 days. So as anesthesiologists, the perioperative care which we give should not add to this insult at any time. So that is why probably we need to discuss at some point how the importance of enhanced recovery, how do you optimize, and how do you continue to ensure that the patients get a smooth recovery is paramount.
This is a very important point because sometimes when we think that the anesthetic management itself is not a culprit, but the quality of care or the something surrogate marker that we are looking for the provision of a quality care anesthesia will have influence. I think we'll be coming into detail a little later about it. But as you rightly said, we need to understand that why this tumor metastasis happens, because there will be influence of some of the factors in the perioperative care, which will fit into the seed and soil hypothesis for tumor metastasis. When we say that there will be certain mediators which will be released, we were talking about the immunomodulation or immunosuppression. So when these events will happen, they will lead to change in the various vascularity around the tumors, and when they are being handled in the perioperative care, they would have certain issues. And there will be certain angiogenic factors also, which will lead to the release of these cells into the system. So the system will try to control them, will try to phagocytize them or destroy them. But sometimes they can survive into distal organs, and that is what the soil hypothesis, seed and soil hypothesis mentions about the concern of cancer recurrence. And way back around 15 years back, with this pathophysiology or with this seed and soil hypothesis, they think that probably certain factors in the perioperative care are responsible for the metastasis in perioperative care. We also welcome Madam Dr. Lalita Gauri to the panel discussion. Ma'am has a vast experience in managing the onco-surgical patients. She is also professor and heading the department at Chandigarh. We also need to think about the immune response, which talks about the concerns in the perioperative care of cancer patients. I can request Dr. Sanjay and Dr. Raj to comment upon that why the immune response is changed in patients who are undergoing surgical procedure. You are mentioning about the drugs also. So is it the reason for increased chance of metastasis? We always talk about, we have seen in just recent past about the COVID, where we're talking about the immunomodulation. We also talk about chemotherapy, we talk about immunosuppression. Do you think that immunosuppression or immunomodulation, because of various factors, are they responsible for cancer recurrence or cancer metastasis? Dr. Sanjay?
Yeah, they do contribute. That is the single most important factor besides the inflammatory response. These two things combined together definitely contribute to the occurrence of the recurrence. So immunosuppression will occur because of several reasons. The chemotherapeutic treatment before surgery, the surgery itself, the stress response generated during surgery and anesthesia, and a badly conducted anesthetic will certainly cause immunosuppression. Severe hypothermia, which is not cared for intraoperatively, all these things, factors, even blood transfusion, a large amount of blood transfusion requirement can cause immunosuppression, and coupled with inflammatory response, which could be because of some of our anesthetics, it will definitely contribute to recurrence. Now, how much it contributes, we do not know. We do not know.
Rightly said. I think our body do have an immune surveillance system where they will try to identify and capture the tumor cells which have probably invaded from the primary side and go into the circulation system or sometimes into the lymphatic system. But yes, they will try, and if this immunosurveillance is altered because of any immunomodulation that can happen because of stress factor, because of the drugs, because of the hypoxia, because of the blood transfusion, or any end factors, and these probably would lead to the tumor surveillance strategy of the body as a defense mechanism, and probably they will lead to. I'll come to Dr. Lalita, madam. Ma'am, are you okay?
Yeah, absolutely.
Right. So I think I just bring this question we have discussed in the beginning also. Anesthetic techniques and drugs, they can cause recurrence and metastasis. Can you think of, there are certain factors on the screen, madam. Do you think these factors have some role in cancer recurrence? We talk about stress, we talk about inhalation agents, we talk about opiates, blood transfusion. Do you think are they real the culprits? Or if they are in the safe hands, it's not actually they are the culprits, but the correct usage of this probably can prevent or lead to a cancer recurrence.
Okay, let me put it this way, that surgery by itself is a tumorogenic environment, as we call it. And I think it would be best to first actually quote literature or look at literature. So the 2019 article in Lancet, which was one of the large randomized trial, where they compared two different anesthetic regimes in breast cancer, where they did a regional anesthesia analgesia, where the paravertebral block with propofol sedation was given, and they gave general anesthesia with sevoflurane with an opioid. And they saw that the cancer recurrence was similar between both the groups. And it was like 10% in each group, with where there was a medium follow-up of 36 months. So they said that that particular big study was one of the first very big study which said that, actually there is no difference. So this was as far as the anesthesia technique was concerned. And then there was a follow-up analysis of a data where they had 1,700 patients who underwent a major abdominal surgery or a thoracic surgery, and they were randomly assigned to an epidural general anesthesia versus a general anesthesia alone with post-operative opioid analgesia. And again, the overall recurrence or recurrence-free survival time was similar in a follow-up period of 5 years. Then we had in IJA in 2000, I think 18 or 19, there was a very nice study which was published, but it was just a small study, 194 patients from Trivandrum, if I'm not mistaken, which did they retrospectively looked at their data for patients who had received perioperative blood transfusion. And they very strongly did say that perioperative blood transfusion definitely is a culprit as far as cancer recurrence is concerned. So that was 53% versus I think hardly a 12% or something like that. Now, when we look at on this list, if we look at psychological stress, we look at hypothermia, we look at pain. These are specific reasons where we see immunomodulation by itself, where things like your what you had said in your previous slide, and your natural killer cells get affected, your alpha adrenergic responses get blunted. So this is actually immunomodulation, where you're creating a circumstance where if there is a micro cancer sitting somewhere, can actually grow further. So it is not that whether you're actually taking something and seeding it somewhere else. It's something where a cancer cell, which possibly could have got killed by the immune system, is probably just working better. So I'm just quoting literature. Now one can probably talk about their individual experience, what they have seen in their clinical practice.
Right, thank you. This is an open panel discussion, so any of the participants, they can experience, any experience they can share, or even they can ask questions, whatever they have. So you can unmute yourself and ask questions.
To quote out of experience is very difficult. We do not know what technique I use, which we all try to ensure that the patient gets perfect analgesia, perfect sleep, perfect normothermia, minimum amount of blood requirement, enough opiates or epidural analgesia to blunt the stress response. Everything we do with the aim of providing the best environment for surgery. But is that environment good enough to prevent or cause recurrence, I have no experience. I don't know. It's so difficult. It's like finding the cause for cancer. We don't know
So,
how cancer
I,
also
I
comes.
fully agree, I fully agree that right now the data or the experience, the evidence or the experience, both may be
okay.
indicative of something in one direction, but we do not know because you're absolutely right that one very key message that is coming from all the experts is that whatever the standard of care is, we have to follow those there. We know that we don't have to let the patient hypothermic. We know that anything which is given externally to the patient is harmful for immunomodulation like blood transfusion. We have to give a good perioperative analgesia. But still, when we're talking about the immunomodulation or immunosuppression or change in the immunosurveillance system of the body, do you think, Dr. Raz, opiates, specifically with regards to morphine, has some concerns with regards to the some change or modulating the system which may be responsible for the cancer recurrence?
Okay, thank you again, Rakesh. So we talked about three aspects when you talked about tumor metastasis. That is one, um, inflammation, immunomodulation, and generation of certain growth factors and suppression of certain factors. So when you look at opioids, um, opioid is definitely high upon the radar in terms of chance of recurrence. And among the opioids, morphine is again a very high. This is because of multitude of factors. So basically, opioids are implicated because they have got immunosuppressive quality. And again, we are reiterating the fact that NK cell forms the important part of body's defense mechanism against cancer metastasis. Opioids have a tendency to reduce the activity of natural killer cells and neutrophils. And there is another important aspect that certain tumors, the tumors of breast, abdomen, as well as lung, they express mu receptors. This overexpression of mu receptors are also implicated in cancer. And when we talk about mu, it's primarily the mu3 receptors. And morphine is something which has got a very high affinity to mu3 receptors and is the main opioid implicated in that mu3 MOR mediated cancer recurrence or metastasis. But thankfully, fentanyl is not implicated as much, and we don't have enough evidence probably on remifentanil. So that is one aspect. But most of these studies which has looked at this morphine, I was just looking at the fine print and looking at the limitation of certain studies. They have continued this morphine for even up as a part of chronic pain therapy to even up to 50 days. It's not exactly the perioperative morphine which we give for 2 or 3 days. The second part is when they did a subgroup analysis of thoracic cases which received morphine, they realized that the patients who had major resections obviously received morphine for a longer days compared to the minor surgeries. So there are many confounders, and at the moment, probably there is not enough evidence to move morphine out of our practice. But yes, because of the EGF factors and the angio neogenesis and other tumor progression proliferation risk, it is better to use opioid as a part of multi-modal analgesia and try to go for an opioid sparing pathway. But I will say that there is, if you ask me, my experience, I do quite use quite a lot of neuraxial opioids. And most of the time, the dose used is very less. So I will probably ask my co-panelists what is their opinion on neuraxial opioids. I wanted to search for evidence literature, but could not get any substantial evidence about neuraxial opioids because for lung cancers there are a lot of centers who give single shot intrathecal morphine and paravertebral as infusion. Um, And even we used to give for thoracic cases single shot epidural morphine. That will give you at least 24 hours. This one. So I don't know. There is something which we can definitely discuss.
You're right.
Neuraxial opioids, I think back in.
The
I
whole
think-
conundrum starts with the opiates around 2 decades back about the cancer recurrence, and the culprit was then thought of. It was hypothesized, maybe the morphine, and this is how we started with cancer recurrence and the anesthetic technique is its implication. And you rightly mentioned that we are moving towards opiate sparing. That's for true because they have many other benefits. People are using different terminologies. And there was a time when people were very fancied about opiate-free anesthesia. Because if we think that opiate is a culprit, should be looking for an opiate-free anesthesia. Is it reality? Is it feasible? Madam, Dr. Mitra, Dr. Raj, Dr. Sanjay, any one of you?
I think Sanjay sir showed this because opioid-free anesthesia is one of the terminologies which I think is very, they have a SOP actually in their breast OT. So I think Sanjay sir should answer this question.
I think it's very easy to practice opiate-free anesthesia in small surgeries, lasting for maybe less than 2 hours around that time. But if we talk of major surgeries lasting for hours together, uh, mm, it will be a nightmare if I don't have opioid for use. Yes, I definitely and certainly put an epidural for thoracic and epidural for, of course, laparotomy cases, which will go on for a long time, and that will certainly bring down the amount of opioids used. But opioids cannot be wished away at this point of time. Maybe shorter surgeries, surface surgeries, yes. But opioids are still the mainstay of the management of general anesthesia for mutilating surgeries. Now, only having a neuraxial blockade available in a continuous infusion manner may not be sufficient to ensure the perfect analgesia required for such surgery. So at present, opioid-free anesthesia in major surgeries is not a great thing to think about yet. Having said that, you have mentioned that fentanyl is safe. There are two studies. One has implicated fentanyl very badly in the under the suspicion of that also being responsible for recurrence, as bad as morphine, and the other study refuted it. And these various studies which are available to us, they are all uh, against each other. Almost every aspect establishes something. The second study comes, it destabilizes the earlier concept. So, no opioid is safe, can be safely called as safe from the point of view of uh, causing less immunity or something like that, or less killer activity, natural killer cell activity effects and all that. I don't think fentanyl is equally to be blamed. Uh, I think this common sense should dictate us to use all these drugs in the least possible amount and still ensure adequate analgesia and anesthesia. And therefore, uh, as we have been saying so many years, balanced anesthetic technique, where everything is used together to give a particular product, and each dose, each modality uses the least dose required. That can possibly, say, inhalation agents are implicated in recurrence, opioids are implicated in recurrence. So instead of inhalation agents, use propofol. Again, if you use propofol continuously and eliminate any inhalation agent, you need uh, monitoring cerebral function to ensure that the patient is asleep. All these things, if we are very keen that even we have knowledge that certain agents are definitely implicated in causing recurrence. So if you can avoid using them or using them in minimum quantity, say let's take away sevoflurane and use only uh, propofol infusion along with opioids minimum, the neuraxial continuous blockade, and also lignocaine in continuous infusion, which is also a good analgesic and has a good anti-tumor activity, a good activity to suppress inflammation. Such combinations, if you can innovate and give, though it is recommended that you need not change the technique of anesthesia today on the basis of the evidence available for recurrence, still, if we know that from laboratory findings that certain agents have definite tumorogenic activity, try to avoid them and still manage to give good quality general anesthesia. I would prefer that.
Can
So
I please add
I
something?
Yes,
Sorry,
please.
yeah.
sorry.
Sure, madam,
Uh,
please.
I was just going to say that there is some this thing in literature where they say that if you look at the role of MOR in cancer progression, that is your mu opioid receptors. So actually, methyl naloxone, who has been used as that's an antagonist, it has been shown to have beneficial effects in halting cancer progression and metastasis. And this has been seen in patients with end-stage cancer, where it was actually been given to reduce constipation, and they have showed an improved overall survival. On the other hand, it has also been shown that in mouse models, depending upon what is the cancer cell biology, in there's some breast cancer and glioma, morphine actually has shown to have an anti-tumor effect. Now, when we talk in terms of our practice, one of the things I've not read in any of the literature is that when we talk in terms of immunomodulation, at what absolute neutrophil count? So, if are we looking at the total, our TLC count, our ANC count? Is our patient really immunosuppressed at the time that the patient is actually coming onto the table? At that point, is that morphine really harming the patient? Or maybe someone who's coming with normal values and then we are giving morphine intraoperatively, is that okay to give it at that point of time? So I think maybe our labs also, we should look at our labs a little bit more carefully when we decide our opioids on the table. That was just something that I do on table, but it's not, I mean, I haven't come across literature that tells me to do it.
That's true. I think a couple of studies are coming and they're ongoing regarding the pharmacogenomics of the impact of these drugs, individual drugs on an individual patient. Probably individualized medicine may be coming up a couple of years later where they will be talking about these drugs are safe for this particular patient and that we need to look for based on their genomic profile. But yet to see, we have a good comment from Madam Dr. Kalpana Balakrishnan, ma'am. Can you just unmute and you were talking about, mentioning about the neuraxial opiates versus intravenous, and one review mentioned that they don't have much difference. Can you elaborate on this, madam?
Yeah, hello, good evening. I just remember that I read one Cochrane review where it did say that, the spinal and epidural opioids, intrathecal opioids, do not have as much of an effect as an intravenous opioid on the implications of cancer recurrence. Maybe the mu opioid receptors itself are not enough, affect, enough filled. I don't know what the cause is, but I would assume that less are occupied so that there's not much of a immunomodulation.
Maybe as Dr. Raj was mentioning, ma'am, maybe the reason is that we are not giving the high dose where the suppression of the various cells, NK cells and other things are not altered or modulated much. Maybe the volume of the quantum of the drug is less when you give neuraxia as compared to the intravenous. So I think that could be one of the reasons. And that's why probably, so I use a lot of intrathecal morphine for these patients, especially when they are long surgical procedures. And I found that the total requirement of opiates in 24 hours are much reduced. A single shot of intrathecal opiate for a major surgical procedures almost reduce the intravenous requirement by 90%. So probably I think if that, I do not have evidence for it. I do not know whether it will lead to decreased recurrence or not. But definitely I can say that the amount required of opiates for a good analgesia is reduced. And that's why probably, as Sanjay sir mentioned, we have to look for a balanced anesthesia technique. Though we started with balanced technique, We moved towards opiate free. And then we said, no, opiate free may not be so good because pain itself is an important marker for the recurrence because it causes immunomodulation. And that's why we moved opiate sparing and starts using the combination of the drugs where opiate is being used as a balance technique. And probably we were able to achieve the balance between the two by using these type of techniques where we add on the regional techniques as well. But coming to the other drugs,
can I add one more thing? Can I
Absolutely.
add one more point, please? Yeah.
Yes.
So I completely agree with what all of you have discussed so far. So one interesting article which I read was it is not the morphine per se which is the culprit, but when you give intermittent bolus of morphine, you have breakthrough pain in between. That produces stress response. Somebody has written like that also. So if you are giving morphine, it is important to ensure continuous analgesia. There is one interesting aspect. The second part is you asked a question about opioid-free anesthesia. I think there is a problem of huge amount of opioid addiction in US and UK. I have a feeling that there is another agenda to reduce the opioid addiction that they are promoting this, because even in the first year medical school in UK, they are telling the students that okay, you are in a primary health center, opioid addiction has gone up from 9% to 14%. So they are made aware from a very early stage about opioid addiction in the community. So that is another aspect. The third aspect is yes, opioid has certain disadvantages, especially morphine, but on the other hand, it has got certain advantages in terms of suppression of stress response. And we need to decide, opioid is only one aspect of anesthesia. Other two main anesthetic which are implicated are volatile anesthetics and steroids. So if you are not using a volatile anesthetic, other option is a propofol based tiva, and all of us, you are giving propofol based tiva generally adds an opioid. If you have remifentanil, you add it, but now probably you have dexmedetomidine. Even that one has its own problems. If you look at the animal studies, even dexmedetomidine predisposed to cancer. So you need to get that balance somewhere, and individualizing that anesthetic for that particular patient forms an important part of practical anesthesia. So till the time more evidences come and more level 1 evidences come, I think, thanks to our society, we are reasonably aware.
I think this is an important point, and we need to generate more evidence, which will be more of a concrete evidence rather than looking for some markers, small markers, because now we are moving towards having very individualized medicine, and we are also looking for patient-centric outcomes parameters, whether they are being affected or not. Sanjay sir, you were mentioning about the other drugs that we can use in these patients. Do you think, do we have some role of infusions like lignocaine infusion, dexmedetomidine infusion?
Yes. Lignocaine is a definite. Lignocaine has a good profile as far as the recurrence issue is concerned, because it helps to reduce inflammation. That is number one. Provides enough analgesia. It has a good quality in being not a contributor to recurrence. And if we have lignocaine infusion at about 2 milligrams per kg body weight per hour, it can help you reduce the opioid usage to a great extent. And this coupled with a neuroaxial lignocaine, you have a good ideal condition to minimize the opioid use completely. I think lignocaine has a good. Besides lignocaine, you can also think of non-steroidal anti-inflammatory drugs, NSAIDs. They have a profile which helps reducing the recurrence or not contributing to causing the recurrence. They, by the name itself, we know they are not pro-inflammatory drugs. So their use as an adjunct also can help you reduce the consumption of opioids.
And
I think
another aspect of lignocaine is lignocaine can induce apoptosis in the tumor cells. So there are certain studies which have shown that lignocaine can directly cause apoptosis in the tumor cells, but not in the normal cells. So, but unfortunately, for this effect to happen, it is you need more like a high concentration of local anesthetics. So this kind of concentration is seen only with tissue infiltration. So probably when we are, this is again, there is no study to substantiate this, primarily the animal studies and this one. So in the future, Dr. Rakesh told me that some of the future studies directions may be good. So a lot of studies in breast surgery is on paravertebral blocks. So somebody can actually explore whether this apoptotic potential of lignocaine with PEX1, PEX2 or subserratus block is helpful in cancer survival. So that
a
is one
couple of
aspect of lignocaine.
a couple of studies are ongoing. I think the last studies from the Western population. We need to wait for their data to come up because they are good follow-up studies. And then we may be able to provide concrete evidence that whether to use it or not. But as of now, what I can gather from all the experts is that we have to go ahead and do a balanced anesthesia technique rather than sticking to one group of drugs for your perioperative management.
Can I just add something? But
Yes,
we
sure,
must
ma'am.
all realize that when we give any form of a regional anesthesia or analgesia, it is actually it says that it reduces your cancer recurrence by several mechanisms because it's actually reducing your stress response to surgery, whether it is via pain control or by the sympathetic blockade itself. It reduces your require for the opioids that we are saying that it's possibly the opioid that is causing the problem, or the volatile agent that you're using intraoperatively, or even the direct effect of your lignocaine that you're putting into your epidural or your whichever nerve block that you're giving. So, and this has been actually, there was a meta-analysis of 1,300 and almost 700 patients plus, and it has actually shown to have a much more overall better survival, and if just given general anesthesia alone. So regional anesthesia has, multiple effects, and it's actually, negating your other things that, with the lower requirement of your opioids or your volatile agents. I just wanted to add that bit or reiterate what everybody's just said.
Perfect, ma'am. I think this is
Rakesh, I want to ask you one question.
yes.
Sorry, it's reverse because yeah. So when I was preparing for this talk, one concept which I noted was about minimizing oxygen debt. Okay, so one thing which is often underreported or in anesthesia is that we um, there are multiple episodes where you can have tissue hypoxia, either because of an imbalance between oxygen supply or demand, decrease in cardiac output. And you will agree that there are multiple reasons why anesthetic, whether it is GA or regional, can affect your cardiac output, especially in an elderly with cardiac comorbidity, can chemotherapy induce cardiomyopathy. A lot of things are there. And we tend to support it with a touch of noradrenaline. And many times we don't look at the area under the curve. We are a lot of people, we tend to look at only the numbers. So cardiac output is often compromised, and there is tissue hypoxia. So this hypoxia can produce something called hypoxia inducible factors and can cause release of vascular endothelial growth factors. Both will produce angiogenesis and tumor progression. So I don't know how significant it is clinically or in terms of survival advantage, but this is again part of a good anesthetic that we should be meticulous in avoiding this imbalance and produce oxygen debt. So the question is, should we be looking at cardiac output for a major surgery as a monitoring? And is lactate good enough surrogate to look at it?
I think this you have raised very important concern. One thing is clear that the the sequence of events for hypoxia leading to HIF, leading to angiogenesis factor release, and possibly hypothesized as being the pro-carcinogenic phenomena. And it has to be taken care of. And this could be a respiratory as well as cardiac issues. And this could also be related to the various hemodynamic perturbations that happens in oncology surgery, major oncologic surgical procedures. We do not know that which is the actual factor. And there are a couple of studies going on, the fluid resuscitation versus low dose vasopressors in these patients. We also do not know whether the lactate levels that we are measuring for this is actually giving an indicator of a tissue hypoxia. Because finally, we are talking of the end organ perfusion in these patients. We do not know how they are level. And as Madam was also mentioning, that it is not just the effect of one component. It will be of multiple components. The fluid balance, the respiratory status, the temperature status, the temperature homeostasis in these patients, the effect of various other drugs, like, for example, HIPEC surgeries, where they induce or give some amount of intraoperatively chemotherapeutic agent also, or the preoperative effect of chemoradiation. We do not know which factors will be the two factors. But yes, in future, we need to look for, can we identify some definite predictors who on identification can say that these patients probably, maybe we can say as a predictor of the cancer recurrence. We need to look for those factors, and probably the future studies may come out with this. But definitely we can say that we have to avoid hypoxia, whether it is cancer, non-cancer patients, but we have to. Now moving to the next. Yes, madam.
Just like hypoxia has its own problem, one should realize that the tumor cell is always trying to, find a way to get more oxygen. So hyperoxia also facilitates proliferation of tumor cancer via a positive effect on angiogenesis, and it forms the reactive oxygen species that damage the DNA. And there's one study where there was a post-hoc analysis of the proxy trial, if one remembers, where almost 80% of the oxygen was given during the the intraoperative period. Even though the frequency, I think, of the recurrence of cancer was similar between the two cases, but the time to diagnose a new cancer or a cancer-free survivors was shorter in periods who received 80% oxygen. So it says that hyperoxia could also actually, proliferate tumor cells. So one should remember that as well.
That's why I think even the balance is required for oxygen also. Too less or too more, both may not be good for these patients. Coming to one aspect which was raised earlier with regards to the various liquid blood solid state issues. We were talking about anemia. We were talking about changes which happens because of blood transfusion. We know that there are studies where they say that you were putting this study, madam, that the blood transfusion has some impact on these patients also. And we know that apart from various blood-related risks, cancer recurrence is one. So I would request madam to elaborate that these surgeries are major risk surgeries. There could be nutritional anemias. There could be the effect of chemoradiotherapy preoperatively in these patients. How you mitigate or how you manage the blood transfusion practices in your experience for patients undergoing cancer surgery? Ma'am, you are muted. I think you got muted, ma'am.
Sorry. Can you hear me now?
Yes, ma'am.
Yeah, so one is implementing ERAS, where you try and look at all your patients with anemia when they first come to the surgeon. Make sure that they are put on to iron supplements, and you try and build up their nutrition. So working on them starts right from there when they are posted for a bigger surgery. Secondly is to move towards leukodepleted red cells or try and get fresh blood. Fresh blood is very rare, but leukodepleted red blood cell transfusion is definitely come into the picture. Ideal word, meticulously select your surgical cases, or you would want to fully optimize preoperatively a good nutritional status, which doesn't really happen. And obviously, if we can, use our anesthetic techniques where we can make sure your patient is not completely vasodilated, or you haven't overloaded your patients. Say, for example, you're doing a hepatectomy and you've kept a low CVP, or you have, really filled them up and now you're getting a venous ooze. So all these things I get a long way in terms of making sure that how you handle your blood loss, or you are handling your anemia in the perioperative period. So autologous transfusion is very, very, I think it's quite controversial. I've been trying to convince our blood bank here. Guidelines as far as the blood bank department concerns, they do not encourage cell salvage. They can, that preoperatively you do autologous donation and do acute normobolic hemodilution, and then you give them postoperatively. But reinfusion is a complete no as far as oncoanesthesia is concerned, as far as the guideline is concerned. A lot of us are now become very comfortable with using tranexamic acid to reduce bleeding. It's safe, it's inexpensive, but studies, I haven't, there are no study. I don't think I've come across any study that says whether it's really safe as far as recurrence rates are concerned.
Right. I think whatever say the immunomodulatory effect you rightly mentioned, but we need to look for various prehabilitation aspects in these patients so that we can build up. We know that oncosurgeries are time-sensitive surgeries. We cannot wait for long durations. But definitely, as you mentioned, you use the word ERAS somewhere. Probably they are helping these patients with prehabilitation component to it. We can try to optimize this patient, or at least have an optimizing effect, so that they can bring into the practice of giving low blood to these patients and low transfusion rate in these patients, probably having good outcome. Dr. Raj, Madam mentioned about the ERAS protocols. Do you think ERAS protocols, they are well known for various GI surgical procedures? Do you think they have some impact on the cancer outcome, maybe cancer sickness or otherwise?
So, if you allow me to take that question, we said that cancer is a disease of old, and a lot of patients who come for cancer surgeries, they are elderly, they have significant comorbid illness, especially cardiovascular illness. Frailty is a major problem, and poor nutrition and the psychological effect. A lot of things go in a vicious cycle. It is very important to optimize. So ERAS definitely has a role, but the role in survival is not fully proven. But something which we can explore is this enhanced recovery can probably allow these patients to have early return to intended oncological therapy. So if that can be taken as a surrogate of survival, probably it has a role, but more studies are needed to conclusively say that adopting ERAS guidelines will be beneficial. But all the points which we have discussed, that you need to optimize, you need to develop, minimize the postoperative complications, you need to have a good functional recovery. When you talk about a functional recovery, this riot is again a bit, you need to clearly define riot. It's not exactly the day you go and start the post-op chemotherapy, whether the patient is able to take the full dose chemotherapy. Do you need to stop that chemotherapy, or should you continue with a reduced dose because patient is not tolerating? All those things are important. So a good functional recovery is paramount, so that this patient is ready to take that planned on chemotherapy at 4 weeks. According to the institutional protocol. So that way, I think ERAS forms an important part of our perioperative care.
I think ERAS, you rightly said, sir, ERAS has given many benefits to us from various aspects. So probably if you follow those protocols, we are moving from, say, longer acting drugs to shorter acting drugs. With Abhijit Nair also mentioned about this. He was talking about lignocaine versus ropivacaine and bupivacaine. Probably we are moving to those aspects, which probably appears to be safer. But I think we are coming to end. I will just ask one question from each of you. From your clinical experience, can you just share me your practical perioperative management in few lines of a particular type of surgery? Maybe Dr. Raj, you can take up GI surgeries. Dr. Lalita Madam can take up thoracic surgeries. Dr. Sanjay can take up head and neck surgeries. Just brief outline of your management, how you do, which regional block usually, and what monitoring you do for the safe outcome of these patients.
Okay, so in the my current hospital and even in CMC Vellore, um, um, we were probably doing a moderate adherence to the IRAS platform. Probably we don't touch 70% of the IRAS, so we cannot claim that we are doing all the principles of preoperative management, because many a times what limits us is the time. Okay, so if the surgeon decides a date, you cannot say that no, he's not fully optimized, and I need at least 4 to 6 weeks for full optimization. So whatever time is available, we work towards that. Optimization of comorbidities is done, but nutrition and supervised physiotherapy or high intensity exercise interval training and all those things we are not doing. Thoracic patients we were doing because they were admitting the patients and doing, but abdominal patients, it's 50-50. So generally, we have gone towards a tendency of minimizing the benzodiazepine pre-medications at CMC Vellore, so that we were doing it. The thing is, if so one important thing when it comes to IRAS is to realize that surgeon is a equally important or a more important part, because we said the surgical insult is a huge determinant of surgical recurrence. So a lot of these surgeons are going for minimally invasive surgery, and now we got a robotic at CMC, so people are moving towards that, so that surgical insult is less. So if the uh, surgeon is planning a minimally invasive surgery, most of the time what we do is we go for a block, because now we are not doing too much of epidural. But if it's an open surgery, I'll combine it with GA and epidural. If I'm giving epidural, I tend to give a one dose of neuraxial morphine, probably about 3 milligram, and postoperatively, maybe at 12 hours, we'll start a infusion after a bolus. So that is the regional anesthesia plan. Always it is multimodal analgesia. Paracetamol is given for all patients unless there is a hepatotoxicity. The NSAIDs are given, but we are a bit cautious when somebody has long-standing diabetes and has poor preoperative renal disease. So whosoever it is possible, we give. But we are slightly cautious with the NSAID because we don't want to have a morbidity. Renal failure can significantly affect. If you look at the theory, I should not be using thiopentone and ketamine, but thankfully, most of us have moved away from that and inducing with propofol. And fentanyl is the common drug. Here, we have an option of giving propofol, remifentanil, tiva in Muscat. But in India, I used to give propofol, fentanyl, and a muscle relaxant for induction and balanced anesthesia. So that is again another important aspect. Too much of anesthesia is bad, because the inhalational anesthetic is a major culprit. It can produce significant suppression of NK cell activity. It can produce that HIF. It can generate vascular endothelial growth factors. So, and even if you don't think about cancer recurrence, too much of anesthesia in an elderly patient can produce post-op cognitive dysfunction and other risks. So I am very careful that I try to give about 0.7 to 0.8 MAC, not more than that, just to prevent awareness. And if possible, I do depth of anesthesia monitoring. But we had a luxury of having depth of anesthesia in most of the theaters. But whenever possible, yes, ensuring optimum analgesia, and wherever possible, using some kind of a cardiac output monitor or something, or even dynamic indices to have a decent balance between too much fluid and too less fluid is also practiced. So that is my plan.
Perfect.
So,
Madam Lalita, ma'am.
So I think the only thing we do little differently than what Dr. Raj does for his abdominal cases is I put in an epidural in all our thoracic cases. And that brings down the amount of opioid that we really require post-operatively, or for that matter, intraoperatively. We just about probably use just for induction, we use a little bit of maybe fentanyl for intubation. After that, I don't think we really need to even top them up for the rest of the case. So even whether I'm doing a 3-stage esophagectomy or if I'm, doing any of the lung cases, if I have a good epidural in place and it's working well, I really don't require much of opioid subsequently. We tend to take out, the only thing different in the post-operative period is that all our 3 stages of esophagectomies, we have a subset. We've seen in my current place, they are really old. I'm seeing a very, they're almost, between the age group of 65 to a 75 that they're coming up on my table, and really frail because it's a rural area, and the time we have to ventilate them post-operatively. They have bad lungs because of the parali that is burnt in this belt. So the lungs are really bad. So I'm ventilating all my 3-stage esophagectomies overnight, and post-operatively I find it very easy to wake them up in the morning because I really haven't used any fentanyl or morphine. They just need a little bit of propofol through the night just to help them tolerate the tube, and they really do well. IRAS, we have, since we are a sister concern of Tata Cancer Mumbai, we have replicated their practices in terms of IRAS. Our surgeons are trained from there, so we try and implement it as much as possible. We are rarely putting in big lines. We try and take out our, Foley's and stuff as quickly as possible, get rid of whatever we can on the earliest possible instance. And we get them sitting up probably by the end of post-op day 1, and which I think is very different from what it was when we were training, 25 years back. So that's about the little different things that what Dr. Raj said. I think he's a little, we make sure we put in a epidural for all our thoracic cases. I'm sure Dr. Raj probably also puts in epidurals for his thoracic cases.
Perfect, ma'am. Dr. Sanjay sir, head and neck cases, anything different that you do? I know we are coming to conclusion that we are not doing.
Head and neck
Sir
cases.
was a master of blind nasal. Ask sir about blind nasal.
Yes, the biggest problem of our country is the head and neck cancer, and the kind of cases we get are all those who have difficult airway. So it comes down to using some kind of an awake technique. We began with blind nasal. Even before coming to Tata, I was doing blind nasal for dental cases in medical colleges. But then, when in 1987, we got the first bronchoscope, and the first 45 cases, 1986 or 87, we got the first bronchoscope, and we used it continuously for 45 cases, whether patient needed it or not, and learned how to do it. And I was always sitting next to endoscopy room, where the thoracic surgeons of our of Tata Memorial Hospital used to sit in my room, and I would go and do his endoscopy, bronchoscopy for him, and then call him once I reach the tumor. So that is how I learned my fiber optic bronchoscopy in 1988. And then then Tata Hospital and all other guys working with us never looked back. Uh, Apart from that, that's only a airway problem. Question is, these patients in the past there was no microvascular surgery, but since last decade or two, it's the microvascular surgery which has become more demanding for the anesthesiologist. In the past, you secure an airway, uh, and excision will take about 1 to 1.5 hours, where you control your pressures to such an extent that the bleeding is minimized. Initially, there was a fad to give controlled hypotension. That's gone. Controlled hypotension with the use of nitroglycerin and all that, those kinds of stuff we tried those days, you know. But the question is, those are more detrimental than useful. maybe at the time of surgery, you have a pressure of 60, 70, but then when they finish and go for a coffee and you raise the pressure, he has to come back to ligate few more vessels. So that practice is stopped. Normal tension has to be maintained with good analgesia, and we use narcotics. Now, for the microvascular surgery, the scenario changes. You need more monitoring. You need to have uh, some way of finding that your body perfusion is optimum, because the survival of the anastomosis, whether venous or arterial, is solely dependent on the circulation provided through the anastomosis. The blood flow, the velocity of blood flow, there should not be a stagnation, there should not be a less flow. So the volume is extremely important. It should also not cross the limits at which you get edema of the tissues, and therefore the flap swells. When once the flap swells, there is a pressure on the anastomosis, and you have ischemia of the flap. All those kinds of things happen, and therefore every patient of ours will get a subclavian line, because you can't put a jugular, and we'll get an arterial line, and possibly stroke volume variation, if it is possible. It's not possible to have it in every theater, but, but we try to find out uh, stroke volume uh, variation, on the basis of which we manage to give fluids, and we come to a end point where the fluids have been given enough, and we also bring in noradrenaline in the picture. Now, why? Because the in the past, if you say noradrenaline, the surgeon will jump. Hey, what's happening? So, because they had a perfect feeling that noradrenaline will cause the vasoconstriction in their anastomosis. I told them it causes vasoconstrictions peripherally. The major vessels which you are anastomosing are not going to physically contract with noradrenaline. In fact, noradrenaline, in the face of normovolemia or optimum volemia, will ensure that the blood flows across the anastomosis at a optimum speed, and no stagnation will occur. So a judicious combination of fluids and uh, your catecholamine is the mainstay of the treatment, with ensuring perfusion by looking at urine output, by looking at stroke volume variation, and having all the monitoring in place. Otherwise, the dying flap or a thrombosed flap is a nightmare for anesthesiologists as well as the surgeons. And you, in the middle of night, same day, you have to come back to OT, either for re-exploration or converting this into some PMMC kind of a thing. So that's the only difference. I think these head and neck cases are also need to be subjected to ERAS, because they have not been able to eat well, nutritionally poor, and they also basically come from lower socioeconomic strata. So as such, their nourishment is questionable. So they need, uh, and head and neck surgery can wait for 2 weeks. So you should be able to optimize them. That's the only difference from other.
Thank you so much, sir.
Can I
I
ask
think
something?
One,
yes.
one,
Yeah,
One sec. I have one question. I
Yes.
have one.
Yes,
So
sir.
most of our head and neck cases will come out with a tube, right? Through the recovery, because you can't extubate them on table. They have edema.
yes,
So we just
yes.
we don't ventilate them, but we just bring them out on a tube, and they need to tolerate that tube till next day in the morning till some edema stops, and then the surgeons will extubate them. Now, what is the practice of everybody as to how do you
Dexam,
help them tolerate that tube?
Dexam throughout the
dexmedetomidine.
night. That will suffice. That will suffice.
Sorry, sir. Sorry, what did you say, sir?
Dexam.
Dexmedetomidine.
That's very okay. Yes, that will
Dr.
suffice.
Rakesh, what do you practice?
Yeah, yeah. You practice. We continue. We start it intraoperatively itself, which will continue into the post-operative period till the next morning.
So we have done a study from our center. Two studies has been done, which we have compared with dexmedetomidine versus propofol. and we didn't find much difference between the two. So both are effective. So I think we are using, we do not have a particular drug to be used for them. We are using both of them as per the discretion of anesthesiologist. Both the research have mentioned that both are almost equal with regards to the various parameters. There were some issues about the hemodynamic perturbations, but statistically they were not different in the two groups. So it appears both are okay, but yes, we can add on dexmedetomidine has a good evidence in addition to the analgesia, in addition to the sedation. So appears to be a good drug, promising drug, and it is being used more common. We have been using it for the awake airway management and appears to be a good one in the initial process. And post-operatively, we are using both of them.
Dexmedetomidine has only one disadvantage, that your ICU should be alert enough to notice bradycardia. At times it can be pretty bad. And on the contrary, propofol is also notorious in causing hypotension, especially
And
if you have a
brady.
post-operative secondary bleeding, and the picture will not be recognizable from why it is happening. So your ICU should be aware and alert about it.
But
Okay.
if you see the conventional loading dose, we are not using the loading dose of dexmedetomidine because they causes more of a bradycardia in these patients. The reflex hypertension is not seen. The bradycardia too happens. So we usually use a lower dose of even loading dose. For ICU post-operatively, we don't add on loading dose. We just start it as an infusion dose. So that takes care of hemodynamics, but appears to be a promising drug.
A
So
small percentage of
one
cases,
question for
small percentage of cases will not, relent to these two regimes. In those cases, just ventilate with narcotics and midazolam. Just ventilate till next morning. Don't compromise on sedation,
tube coming
because
out.
the agitated patient with a tube inside his nose is detrimental to the flap itself, right?
That's
So
true.
don't hesitate, ventilate.
Dr. Raj.
Hi. So we all discussed that blood transfusion is bad, and we should try to bring up hemoglobin as part of ERAS or patient blood management, whichever concept you want to adopt. And last week we had a beautiful talk on patient blood management. So in reality, if you define anemia as hemoglobin of less than 12, you will definitely have an incident of more than 50%, or prevalence of it'll be more than 50%. So if the patient is anemic, are we doing IV iron, and who are actually doing erythropoietin, giving erythropoietin, or is it based on a particular protocol?
Regarding the use of preoperative erythropoietin for increasing the hemoglobin?
Yeah, one dose erythropoietin plus IV iron. And if you have 3 weeks, it's theoretically can bring up the hemoglobin to a decent level, because
I agree, but if you see the Indian population, it's more of a nutritional anemia rather than the body system. So even people have started giving them iron supplements, like at our center, because we see a lot of nutritional anemias. So whenever they are first registered, they're starting on hematinics, oral hematinics, because we still have 2 to 3 to 4 weeks. I know that they will not have much influence, but at least something can be depleted by giving them oral. And there are a couple of studies where they have even thought of giving them 2 to 3 weeks prior to the surgery, the one shot of intravenous iron for these patients. So maybe erythropoietin may be suitable for Western population, but I see, as Lita ma'am also mentioned and Dr. Sanjay mentioned, we have patients who are coming who are nutritionally poor. So it is more of a nutritional anemia rather than the body system response for causing anemia. So probably at our center, we are not using erythropoietin, but yes, we are giving them iron for whatever time feasible for us.
Thank you.
I think we are almost close by half an hour. Thank you for the nice discussion. So I think conclusion is that we are not the culprit, at least. We are following the techniques which are more apt But we do understand that the perioperative care of a cancer patient do influence the cancer outcome in a particular patient. We are looking for return to intended oncologic treatment. So we have to use our various drugs and strategies judiciously so that we can provide a safe perioperative care to these patients. We are looking for more evidence in near future. Probably these evidence may be more based on genomic profile, which are various ongoing studies. They will take probably a couple of years more, but I think that's the future. Still then, at least we are not the culprit. Try to continue the balanced perioperative care for these patients, which they require. And the use of strategies, the newer blocks, the use of combination of drugs probably is one of the good options in these patients to give them a good care, a good outcome. So thank you once again to all the panelists for their experience inputs. We usually read various journals, but these type of experience-based discussions are also good because I know if I add the experience of all of you, it will be in decades, and that is what is required for a good clinical care. Thank you once again, and see you subsequently in the subsequent SOPSI webinars. Thank you so much.
Thank you so much.
Thank you. Thank you so much. Thank you. Thank you for the
Thank you very much. Thank you
Thank
very
you,
much.
sir.
Very
Thank
nice
you.
meeting
Thank you, Dr.
after a long
Rakesh.
time.
Lovely. If sir was my MD teacher, so just be on the same panel as your guru is like, it's a dream. Thank you, sir.
He must be proud of you, madam, because you are teachers
hope
to
so.
many, so he should be
I
proud.
am what they taught me.
I
I
am
am
proud of
what
you.
they made me.
I am proud of Gauri. I am
Thank
proud
you,
of Gauri.
sir.
It's a
Thank
good
you.
point
Thank
which
you,
you
sir.
have brought out. Many good points. Many good points. God bless you.
Thank you so much.
Thank
Thank you,
you, sir.
everybody. Thank you.
Thank you. Thank you.
Thank you.
So,
Thank you,
Thank you.
Dr.
innocent
Good
until
night.
proven
for
guilty.
the insight. And I will have thank you everyone for extending us a support to host the session, and I hope you had a similar experience. With all due permission, then I'm closing the session for today and looking forward to hosting you again very soon. Till then, stay safe and healthy, everyone. Have a nice day. Thank you, everyone.
Thank you.
Thank you.
Thank
Thank you,
you.
sir.
Now? We can leave now.
Yeah, thank you, sir. Sure, sir. Thank you,
Unless
sir.
we want to sit.
Yeah.
Good night. Good night.
Thank you, sir.